And then let us know if you're having any trouble hearing. And then hopefully we don't have any tech issues. That would be wonderful. If you have questions that are coming up, I'm going to be managing the chat. I think there's a chat, and then I've got to bring that over there. Okay. Can we use this? Yes. Somebody asked if we can use this as part of our field hours. Is Miss Moore on the call? She could probably double confirm that, or she can say, "What are you talking about?" But I would say yes.
Absolutely, absolutely.
Thank you, Miss Moore.
Welcome.
So, Professor Armstrong, I just broke up, so I don't really know whether you answered my question or not. This is Alma.
Oh, yes, you may. Wait. Are you doing field right now?
She's not.
Okay. So no, it's only for people that are currently in field.
I'll be doing it in the summer, and I wanted to know if this would be, we can get hours from it.
No.
So not in this case. For students who are in field this academic year, yes. There will be some summer professional development offerings, but we'll have to look at what those are.
All right, thank you.
You're welcome.
Okay.
I think I'm going to go ahead and start.
That sounds great. And as folks are coming in, if you can just mute, I think I got to mute myself. But put yeah, questions in the chat as we go along too.
All right. Thank you very much. And I will be talking about some cultural considerations in therapy today. And I am proud alumni. It's
Erum, the volume, I don't know if it's there's something covering up the volume, but it's getting softer and softer.
okay. I'm gonna try to talk louder. Is that better?
Mm-hmm.
All right. So could I have the next slide, please? So my work is funded by an NIH grant because I am NIH funded T32 sculptural fellow, and I want to acknowledge that.
I'm sorry, this is Nicole. I'm still having trouble hearing.
Is everybody having trouble hearing? Yes?
Yes.
Yes.
Okay, let's switch computers. Bear with me 1 minute. Laura, you could hear me earlier. What happened now?
I wish I had the answer. I don't know. But it was good, and I don't know. It's just gotten quieter.
Okay. Well, I'm joining from the other computer. Let's see if that works better.
Okay.
All right. So I am going to. Is that better?
Not yet.
All right. How is this?
Beautiful. That's so
Much better.
All right, there you go. 2 computers in action. All right, everybody. I thank you so much for joining in today. This is a Zoom note, but this is an important topic, and I appreciate so much. Now, I can't even see where I am with the camera. I think I am in the camera. Okay. I want to acknowledge that my work is funded by a grant from National Institutes of Health because I am an NIH-funded T32 postdoctoral fellow. And I also want to acknowledge the mentorship of my professors and other mentors whose work, time, and mentorship has brought me to a place where I am in my research and in my practice. So thank you to all of those who have contributed. Next, please. This is my brief agenda. We'll do a quick introduction and icebreaker. There'll be some poll chat type questions, 4 in total. I will go over some definitions, concepts, examples, discussion, lots of time for discussion. So save your questions, and I look forward to answering some questions and having a discussion. Next, please. So this is a poll question. Please describe your current role. I think you have some choices. So would you kindly do that, Laura? Can we get that? Oh, okay, we got that.
One more minute on this poll.
I think we should be pretty much done, right?
Those 4 people left.
Is there something called closing it prematurely? No, that's fine.
Yes, no, I can close it.
Okay, I think we should be good. Can we get the next slide, please? Do we have the results, Laura, for this?
You'll have to give me a minute because I just put it somewhere that I'm not seeing it. Just a second. Yes, we do have the results. Just a minute. Oh, there it goes. Wait. There it is. Okay, we have 15 students, 11 clinical social workers, 9 non-clinical social workers, and 1 faculty.
All right. Okay, so could we get the next one? Okay, now this is another question. And this you will have to please use the chat feature. Please state what brings you here today. And it could be something just like hanging out, checking out what this is about, CEs, whatever it is we would like to know. 2 minutes maybe, Laura?
Sure. This isn't going to be on a poll though. They're doing this in the chat.
Yeah, this is in the chat. And this is just to be able to manage people's expectations and to just make some clarifications.
Do you want me to shout them out as they come through?
No, I can see them.
Oh, okay, great.
I think they stopped coming in. I think we can proceed. All right, so today's presentation, it is on the relevance of culture in clinical and therapeutic settings. we will not be diagnosing or practicing diagnosing using the DSM. And of course, we would like to contain a lot of information in these 2 hours, but this is not intended to turn everyone into an expert on culture, but it actually is going to start a dialogue so that we can continue our own professional and intellectual development, and then use this as a springboard for future learning on culture. Next, please. So NASW, our membership organization of professional social workers, and it is one of the largest organizations of this type in the world. And here is what NASW says about cultural competence. It says, I'm going to just read it. It is directly from their site. Cultural competence refers to the process by which individuals and systems respond respectfully and effectively to people of all cultures, languages, classes, races, ethnic backgrounds, religions, and other diversity factors in a manner that recognizes, affirms, and values the worth of individuals, families, communities, and protects and preserves the dignity of each. And it says exactly what page it is located on. If it's been a while since we read the Code of Ethics, I think we should all consult it. Next, please. So this is a cultural iceberg. We have seen this in different forms in different places. Culture is a broad context. It is not just looking at international differences in culture, but it is fluid, and it is also looking at the different multitude of microcosms within the United States. And here we can see that some of the aspects of culture are visible and easily identifiable, and then some of them are not. This is what's indicated above and below the sea level. I will just let it sit here for a few seconds, and then we will move on to the next slide. So as we're looking at that, quickly scanning, maybe we can pick out one or two that we didn't think were part of culture, but they actually do appear on the lower part of the iceberg. Maybe attitudes towards age, maybe thought processes. Did we actually think that thought processes were part of cultural cultural background? Concept of fairness. What's fair in one culture, and is it fair in the same way in another culture? Cleanliness. What constitutes cleanliness? What constitutes purity? Assumptions, timings, etc. Right? All right, let's go to the next one, please. Now here's a reflection question. When you think of yourself and your own culture, what comes to mind? And this I would like to see in the chat, and I will answer it for everyone just to give a concept. When I think of culture, what it means to me, it means dress, my dress code. That's the first thing that comes to my mind, and I identify my dress as culture. So let's see some answers for context, and also because then we can see how our peers are thinking. It could be food, it could be friendships, family. We're seeing a lot of music, yes. Food, okay. Yeah. It could be holidays, it could be just about anything. And this is an exercise, and all the questions are an exercise of trying to think of culture in a way that is maybe different from how we have been thinking about culture. Traditions, yeah. Okay, I think we could go to the next one, Laura. So let's talk about racial and ethnic diversity. We know that Americans today are more diverse than we have ever been. And 14% of the population is foreign born, which is a small number if you think about it, but compare it with 1965, not that long ago, when it was only 5%. also very important that millennials, look how many of them, almost half of them, there will be half very soon, are non-white, white being the earlier main majority. Religious landscape changing drastically. And it's not only the religions that are coming from other parts of the world, but different religions emerging within the greater United States. Now, we will not have one single racial or ethnic majority by 2055 per research. Can I have the next one, please? So, how does culture influence how people view their health and seek help and utilize health services? How do we think culture influences that? So, if I have a health problem, why is it that my culture will make me think of it differently? Because it it may influence what I think of my illness. It may influence how much I'm supposed to endure my illness, how I am supposed to report it or not, and how to express it, right? So I may be expressing pain in a word that is not pain, but it could be different. It could be expressed as discomfort. It could be expressed as, I don't know, not feeling well, etc., right? So uh, with the changed composition of societies, it is very important to understand that the expressions that are related to culture are very important in understanding what a person is trying to express. Can I have the next slide, please? So here is another question. We are easy to think that language is a big barrier. So if somebody enters a room speaking a different language, we're almost immediately we identify, okay, this is a person that is different from me because she or he or they are speaking a different language. And we immediately have a disconnect with that language, right? But culture is sometimes not that easy to identify because a person may be dressed like I am dressed, but I don't know what their cultural background is. So based on that, our general perception is that language draws a bigger barrier. Think for a moment and think what in your mind is a bigger barrier. And here is just a word cloud, and it just note some of the languages of the world. Of course, it's not all inclusive, but this is just to give a context. It is also important to understand that with people migrating everywhere in the world, different locations, whether it's by choice, whether it's not by choice, people find themselves in situations where now they have to come in contact, seek help, make friendships with people who are very different from them, who may not understand them the way they were used to being understood by people in a different place, right? So cultural norms and belief systems become very important in how we understand others and how we are understood. So the general thoughts on language and culture. Do we have some answers coming in the chat? I can answer. Oh, it's a poll. Okay.
I can do the poll. Got it.
Oh, okay. Oh, I see. Okay, sorry.
Oh, that's okay.
I'm saying poll, but I'm I'm thinking chat. Okay. We should be done.
No, it's pretty tight. You've got 21 for culture and 16 for language.
Oh, wait. Let's see what more comes in.
There's only 6 left. 6 people left.
Okay, those 6 people. We're gonna need to untie this. It's tied right now. Okay, we can end it and then proceed.
Okay.
Okay.
Ooh, wait, there was one more that came in. Okay, all right. Can you guys see the poll?
No, I cannot see the poll.
You can't? Okay, come on.
Not the results though.
Okay, so 21 for culture, 18 for language.
Yes, and that is correct because culture is a bigger barrier, and some of the folks have already responded to that in that because of course the culture could be it could be the lower portion of that iceberg that we just saw, while language is just a barrier. So let's say there's a language that I don't know right now, which is, let's say, Russian. I don't speak Russian. What will happen if I learn Russian? I will be speaking Russian. I will be able to communicate in Russian. Let's say I really become good at it. So, right, I have overcome that barrier. Can I learn everything about that culture? No. So here's something to think about. And this is demonstrated in practice, and this is also mentioned in literature. So culture, yes, is the bigger barrier. Let's move. So, how does culture matter anyway? This is very important. It influences how we understand health and healing. It How do I understand my illness, right? Is it because I take it as a physical ailment? Is it that I take it as a curse? Some cultures will take an illness as a curse. Some will take it as something else. It is, for example, some cultures do not have an understanding or a word for PTSD. And some cultures will understand anxiety as just a social shyness or something that is a personal choice, but not something that a person is suffering because of a biological reason. So therefore, it also impacts our expectations of personal interactions. So this means that people from one culture, when they're having presentations of symptoms that they understand differently, and now they have to go to a clinician who may understand it differently, and there isn't a common medium to translate that, what happens, right? Of course, then this means that we have a need for clinicians who are trained to work through the barriers, because we can't expect the people to who are consumers of these services to overcome the barriers. It makes sense. So let's say if I was a consumer of a service and there was a really awesome clinician, but who didn't understand my culture, so then instead of the clinician working to understand the culture, I would have to find a way to explain my culture, but that would be very long and cumbersome process, and a lot of people may not be able to navigate that, right? Because I'm in need of a service, I shouldn't be tasked with explaining that. So the burden now falls on the clinicians who are trained to work, and then also it is a benefit because that might not be the only time I would use that understanding and knowledge that I've gained about cultural navigation. It is also important because we now see that the diversity is increasing, right? And therefore, more people from different cultures, different backgrounds will be in need of services. And then what do we do? So, do we go to each culture and each background and try to identify a therapist, right, or a clinician from that? Yeah, we can do that. But what if those cultures do not have we don't have clinicians from those cultures right now to serve the population? So this is also another reason that we need to have therapists who are able to serve these groups in an effective way and an inclusive way. Can we go to the next one, please? So we, of course, being clinical social workers, and we understand that mental health is a continuum, right? It ranges from having good, great mental health to a disorder, but it's very rare to just be on the one end at a given time, and people who also end up on the end that puts them in a disorder criteria, they don't get there. It's not a light switch. They don't just appear there one day. So this is what it means, that it is a continuum, and an individual may vary along this at different points in time. So for example, at the start of the the COVID and the restrictions, a lot of people who may be having some mental distress did not have that distress. And as the isolation and the restrictions continued in terms of weeks and months and now almost a year, so they're at a different point on the continuum. So this is an example relevant to the COVID-19, but let's say a person who has some issues dealing with, let's say, family violence, right, did not start out with some mental health needs on day one, but as those problems progress, as time increased, then the person increases in the presentation of symptoms. So this is what it means about the continuum. Can we go to the next one, please? Clinical social workers, very, very important. We are the leading mental health service providers in the United States. And this is, I have noted a congressional report. So please, if you need to cite this is a congressional report, 2018, so fairly recent. There are more than 200,000 clinically trained social workers in the United States. And combined, more than psychologists, psychiatrists, and psychiatric nurses combined. This is huge. So we see that we are present in a large number. We are on the front lines. We are giving direct services, and there is strength in numbers. So this also means that we have a wider reach than psychologists and psychiatrists and psychiatric nurses, and therefore we see a lot more people, and a lot more people in different settings, and a lot more people who may be very, very culturally diverse, and therefore the need for understanding the cultural considerations. Can I have the next one, please? All right, so here is a short list of some cultural differences between a therapist and a client, and I will let it sit here for a minute. Is this all inclusive and comprehensive? No. But this is the first step in a cultural consideration, that is recognizing that there are differences between the therapist and the client. And of course, all these differences, a lot of them will create a power differential. Let's say we have a really amicable and very considerate therapist and who's building trust and rapport. Can that therapist ever fully overcome the power differential? Can the power differential between the client and the therapist ever be fully addressed? No. No, it will never be fully addressed, but the therapist recognizing that differential and then working. So race, gender, ethnicity, a lot of times we see women request a female therapist or males request a male therapist. So we see that. Ethnicity, we can't do anything about that. I want to see a therapist. I can't find a therapist from my country or my town or my city. I can't. I will have to go see somebody that is not from where I am, but will be considerate and respectful of where I am from. So age differential, education, of course, you may see another therapist in your practice, but a lot of times you will not see another therapist. So there will be an educational differential, religion, language, and the list is long. But here's just a start thinking that there will always be some differences, and a lot of them can never be overcome. Can I have the next one, please? Okay, so bias. What is bias? I've put some definitions in here. There's a lot on this slide. I'll try to break it down. Bias means favor for or against something. We know it, but I just put it here, so it's right in front of us. All right, so here's this research that says attitudes and behaviors of healthcare providers are identified as one of the factors that contribute to health disparities. Well, we already knew that, right? Didn't we? We didn't need research for that, but yes, it helps. This is evidence-based. And this study that I have cited here, it is by a colleague, and this is a systematic review. So it took, by stringent criteria, 15 studies that reported the exact same thing. So this is not a small citation. This is citing 15 studies that, okay, the attitudes and behaviors of healthcare providers, they contribute to health disparities. Wait a minute, we thought it was all these other things, the social thing, the social justice, the economics and all. What about The healthcare provider attitudes, yes, it is there. So, well, disparities arise when cultural considerations are not incorporated, which means client informed choices, communication with the client, right? And consideration for clients' needs, spiritual, biopsychosocial, religious, right? And then that leads to disparities in simple language. And this is not scientific language, different outcomes for different groups. So one group has very good outcomes and the other group not so much, right? So this is what can happen uh, with uh, with the providers that are not culturally considerate. Can I have the next one, please? So ways in which culture can impact mental health. Well, there are many, many ways, but I've broken it into um, four main groups. Cultural stigma. What is that? Well, we know that mental health is stigmatized in just about every culture, but in some cultures, much more so than others. Can we think of an example? Yes, some of the Eastern cultures, well, never talk about mental health. Mental health makes you undesirable. What is mental health? It's all in your head. It doesn't happen, right? It could be that. Or maybe at my job, I can't tell people I'm having mental health problems, even though there may be a mental health day. I can't just take it and saying I need it. I'm going to have a breakdown, right? So there is a cultural stigma. Understanding of symptoms. Well, if I'm having a lot of anxiety, but everybody thinks I'm shy, and I've started to think I'm just shy, there is a misunderstanding of the symptoms, and I could be in need of medication or therapy or a combination, but because it wasn't reported, understood, well, I don't get it. Community support. It's very important, and having community support, of course, is a good thing. It's a protective factor. Not having community support is not such a good thing, and it is a risk factor. We see specifically that persons from marginalized communities, persons of color, a lot of times, they're left to seek their own support, right? So there isn't so much. And then resources, a lot of times, cultural resources aren't even there. So there is a real shortage of resources that are culturally appropriate and relevant. And it's not like there isn't anything available. So a lot of times, places, agencies, or groups that are doing something that are very culturally fitting, they're doing it very informally. It is done by volunteers, it is done by paraprofessionals, or maybe a social worker volunteering their time. They're doing it by donated money, donated time, etc. It's not documented, and the results are not reported. Well, if it is not documented, we can't report it as evidence-based, right? It just becomes anecdotal evidence. So there is anecdotal evidence of cultural stuff going on and that it works, but the actual resources, actual translated material, actual funded programs, there's a shortage of that, and we need those. Next, please. Well, very relevant in this time, however, changing landscape of clinical practice. So let's even think pre-COVID. Well, a lot of clients that we saw 10 years ago, it's different from what we saw 5 years ago, from what we saw 2 years ago, right? Everybody was in person. Nobody heard of a client doing therapy for mental health, right? Except for some medication in rural areas. I know that they do some telemed and all of that, but that wasn't very common. Now it's all either a hybrid or just right now mostly. So for example, I'm working 100% virtually with my clients. And if somebody makes a request to see me in person, I very politely decline it in the better interest of the greater society and public health. I don't. So email and text. Now, email counseling is, yeah, there is such a thing. It is a text counseling. Those crisis lines, suicide lines, look at that, right? So the scope of clinical practice, the scope of emergency services has really changed. And now think of it right now. I don't have the exact number because the research right now is so fluid that what percentage, let's take a guess, what percentage do you think, and it's not a poll question, I know there's been a poll overload, but those are interesting questions and I like those, so so you had to deal with those. But let's think, what do you think is a number of the percentage of practice that's taking place virtually right now? A large number, right? Almost everybody that I know is doing it virtually right now. Or if they are doing it in person, there's strict guidelines. And do you think that's going to change? And how is that going to change? So the client now who didn't have the resources to travel, right, but does have Medicaid, does have Medicare, is able to get some counseling because now they don't have to wait for those transportations and requesting a relative to transport. Now I'm getting this therapy. So now when I have a choice of either getting it online or in person, how many of those clients will choose to continue doing it virtually, because that way they will not miss an appointment, they will get the service, etc. We don't know because we're not there yet, but it is something to consider. So the landscape of clinical practice as of last year has changed, and going forward, we will continue to see the effects of these changes. This also means that a lot of people who would not have sought therapy in person because of, again, cultural limitations, cultural considerations, culture. I'm from a very poor neighborhood. I don't feel comfortable going into this office where everybody's so nicely dressed and they look at me strange. I don't want to go, but on my camera I can do it, right? So how will it affect? Next, please. Cultural considerations. I have 3 or 4 slides for that. So there's a lot on this again, but we'll process it, break it down. I'll let you read it quickly. So culture is a fluid thing. A person or persons can belong to more than one cultures at the same time, or belong to a different culture at different points in time in their life, right? We know that it is documented that we have 650 ethnic groups in the world, right? In the 190 countries. We don't know what we don't know about that, right, about those cultures. So many cultures we would have no idea, okay, this is a culture too. So culture becomes really fluid. And it is important to understand when people come into therapy, it could, the problem that they're presenting with, right, or how I am seeing it, it could be from such overlapping circumstance, personal experiences, right, state of the society, anything, perceived discrimination, whatever else, a mix of 2 cultures, living in a culture that they may find hostile, right? So we have to look at multiple considerations. And I know as social workers, we do that. We have these rule out this, rule out that, or this factor or that factor, but let's put a cultural cap on and then look at the culture and not just circumstances. So let's start thinking of it in terms of culture. So let's look at second bullet points. A person with disability struggling with depression, right, needs to address multiple issues. So some of these are infrastructure issues. Well, I don't have a wheelchair available. I'm on the waiting list. So that we can't do anything about. But that is also a culture that a person who is in need of social services experiences, right? Resilience, hereditary traits, social impacts of self-image, opportunities, etc. So if we start thinking of these in terms of culture, we will get a little more insight into the presenting problems. Cultural factors specifically for stigmatized groups, racial and ethnic, whether it is actual or perceived stigmatization, it is very important. It has a huge, huge impact. Can I have the next one, please? So cultural history, very important. Historically oppressed groups, they fare quite low when it comes to the impact of those marginalizations and oppression on their health, mental health, social health, emotional health, all of that. using a strength-based perspective, that is, whatever they identify as a strength. For example, we saw some answers here. People who identified music, family, religion, dress, food. Well, we think of those as what I identify with my culture. Can I use those as a source of strength, right? So let's cultivate that among our clients, but we can only do that if we're thinking of those in those terms. So we can't convey to our clients which we are not clear on or which we don't understand. So examining how whatever culture factors are present, that we could put them in the strengths perspective, which we're already using, but again, putting the cultural thinking cap on. Can I have the next one, please? So culture as a protective factor, culturally responsive services, real scarcity of that, right? Being part of a cultural group can offer protection and improve health and wellness, but it can also be a deterrent. So if I'm part of a cultural group and we meet every week, we meet every other week, we socialize, we talk about each other's, what our needs are, what needs are being met, we talk about reality, we share in each other's joys and sorrows, that's great. But if I'm part of a cultural group, it's just kind of a, I was recruited in a gang, I didn't want to, that's not the culture that could be a protective factor and a source of support for me. So we have to look at both things, but looking at how being in a cultural group can offer protection. So understanding that as a therapist and then offering it to our clients. Laura, your screen is it working? Can you hear me? Am I connected?
Yes, I can. Yeah, I can hear you.
Okay, very good. Okay.
My screen
so, yeah, it's okay. Now we can go to the next one, please. So here's a list, a short list. Of course, it's not all inclusive, but the thought here is to start thinking along those lines. And I love interactive in-person meetings where people can say, oh, what about this? What about that? Let's add that to the list. So short of that, we have a short list. Feel free to put it in the chat if you would like to. Some other counseling techniques, but these are the common, or the ones that we could group, having subgroups too. A therapeutic approach. How is it cultural? Well, it can be cultural. I could be a nurturing client, therapist. I could be a respectful therapist. But if I have that nurturing and respect towards a client's culture, that makes it a culturally relevant technique. Communication. So what is cultural communication? Misconception, just a mention of culture and acknowledging that that's just touching on it, but that's not culturally relevant, appropriate, or fitting communication. So having that clear communication with the client, but the therapist needs to be very comfortable having that conversation. And so, for example, somebody might come to me and say, you know nothing about my culture, I don't know why I'm here, and can you help me? What do you say to that? We don't have to answer that right now, but this is something that in therapy we may be faced with some very very unique situations, put on the spot a lot. Values. What are the client's values? What are my values? How are my values different from the client's values, right? So I could be providing therapy to a client who loves barbecues and wants to talk about that a lot. I'm a vegan. How is that going to go? So, that also becomes like a cultural thing. I have to be able to navigate that. But then self-awareness, where I am at, knowing how my cultural beliefs can be and are and will be different from my clients' beliefs, and how do I navigate that? Of course, we as social workers, we're very self-aware. This is part of our training, our MSW and field curriculum. We are also trained to notice the biases that we may have, and we may work through them periodically. But this is not a given in all professions, because I have attended other professional trainings, and I see that other professions seek to incorporate that through additional trainings, but this is part of our curriculum. So we already have this strength, but just keeping it fresh. So for example, we may already be using these things. Every single one of these probably was part of our MSW curriculum at some point in time. We spent 2 years, right? Or 1 year if we did have a BSW. But then what happens? Do we remember everything? I don't claim to remember everything that I read in every textbook or every class that I did. So what is this? So then this discussions such as this and events such as this, they become a reminder for us to either say, oh yeah, we did talk about that, or yeah, we did, and now it is a different concept, but I can use some of the principles that I learned and then apply it to cultural consideration. So this is what it is. We have studied these at some point in time, but almost like a road sign. We all know we're supposed to drive at 65 when we're on the highway, right? How many times we see the sign, oh, 65, look at our dial and it's not 65. So there you go, the sign, the speed limit sign becomes important. So this is what we're doing here, is some counseling techniques, awareness of clients' worldviews. This is a hard one because the client may have very, very different worldviews from mine, politically, spiritually, cognitively, just very different. And how do I navigate that and work through that flexibility? And then culturally appropriate intervention strategies, meaning also involving the client, not what I think is culturally appropriate for the client, but having them have a say. So this is important, to have a clear communication with the client and setting some goals and expectations in which not just the client's urgent needs as they're presented, but the culture is given a seat at the table. I hope that makes sense. Can we have the next one, please? So, is there a model? This is a lot. This was a mouthful. I mean, yeah, okay, this lady's been talking about culture. How do we do that? We're not born with cultural trainings, and today we are doing one. And what is the expectation? Well, the expectation is that we're going to start an internal dialogue, and hopefully we will be communicating with each other and using our peer networks and support to talk more about culture, because this needs to be part of our professional conversations. So is there a model? Why do we need a model? Yes, there is a model. There are some models. There isn't a need for a model for you to follow if you have your own outline and you meet all whatever you think the client needs are. You're able to navigate those. So you don't have to use a model, but to answer the question, yes, there is a model. If you wanted to look at that, you could, or you could make your own, and you could consult others who may have a little more expertise on culture, and then have a plan. Okay, can you hear me, Laura?
Yeah, I can hear you. Yeah.
Okay. Can I have the next slide, please? There's something in the chat, but I can't. Okay. All right. So this is one model, and I am not suggesting that we use that, but this was showing an example of, if I talked about, hey, we can have a choice to use a model. Is there one? Yes, there is one. This is called the respectful model. It was developed in 1997. And without going into the details of the model, let's just look at what it looks at. So the respectful is an acronym. And look, it looks at religious, spiritual, economic, sexual identity, psychosocial, psychological maturity, ethnic, cultural, chronological development. We never thought of it in the cultural context, but yeah, trauma, family history, unique physical characteristics, location, and language differences. So these could be embedded in different parts of the assessment tool that whatever we're using, but thinking of this as a model to understand where the client is at culture wise, that could be helpful. And I could have my own checklist, or I could just be more aware of the questions that pertain to culture when I'm asking those questions, and then learn from them, not just from family history wise, but culturally. What is the family culture, right? How is an event such as this taken in the phone? Okay. Yes. My dear friend likes this model, and this is a good model. I mean, if I didn't have anything, I would just it's worth looking at, because models, they have something you can fall back on, right? Somebody has put time and effort into it and developed something that they're putting their name on and saying, hey, use this works, or this might work, or this is, we have tested it on in many situations. So model is useful like that. It's always good to have. And then one model shouldn't be everything. Then maybe this model can inspire me to create my own model, because I might say, okay, this model is great, but it doesn't work with this niche of clients that I am seeing. So maybe I could develop another model and do whatever. So it just opens doors of our intellectual and professional development. And it is a great service to our profession. Can I have the next slide, please? So, okay, so the considerations that were listed that are part of the respectful model, for example, and people are commenting, they're holistic, they make sense, we're already doing that, but we're not looking at in terms of a model, and am I looking at all these factors, because they're part of a big cultural picture that the client is presenting. So what happens if we don't? So if I will talk to you about trauma, but I don't want to talk to you about your culture. Or I will talk to you about your trauma and culture, but I don't want to talk to you about your religious background. So the client is either forced to seek these services elsewhere, or worse yet, not talk about those at all. And they may have a very hard time navigating. So what we're doing, if we're not addressing all the considerations that, for example, were mentioned on the previous slide, or a list that I generate myself with 25 items or whatever, missing out key points that the client, that are client to the that are contributing to the client distress, I'm fragmenting. What is fragmenting? Fragmenting means breaking it into pieces. So not addressing maybe some of the very important pieces, and that makes health, healing, and holistic healing very, very difficult for the client. So the more considerations that we are able to identify and address as a social worker, as a service provider, the better outcomes they will have for our clients. Can I have the next one, please? Culture, yes, it leads to therapeutic alliance. So this is important, because we have to have therapeutic alliance. We have that trust and rapport. It is the most critical component of therapy, and not having that can be the having outcomes that we want for the client and not having the outcomes. So this is the overarching goal in the field of mental health. Next, please. Groups. A lot of us are doing groups, right? Feel free to put anything in the chat about groups if you're so excited about groups. I am always excited about groups. I love doing groups, and I was doing it groups with another colleague who is present here. You know who you are, and we talk about it still. We love doing groups. So group work is hard. We have much more of a chance to have diversity in a group compared to an individual client. So if I'm seeing a client, yeah, I know this is my client. Maybe the very first time it's a surprise. I don't know who I'm going to see. I just have bare minimum information. But then when I know the client, that's my client. I know what it is. But a group, I have a group of 8 people, 12 people, 16 people. I will have people from different cities, villages, the groups that I have done in the past. In the heart of town, people were driving 2 to 3 hours to come to that group. And so we did have diversity within those groups. So group facilitators' norms may be very different from the group's norms. And of course, this is almost a given, because with my one client, I could say, oh yeah, this is a client that I don't have to put in a lot of effort in trying to understand what they're saying, how they're saying what they actually mean, versus a group. Well, there will always be, the group dynamics will always be harder. So we need to make it work collaboratively. And we're not just talking about international groups here. We're talking about local groups that could be very different. So let's say I have a group in which, based on the chat comments, well, this is a group and we're trying to see what is the best support system, or what is the best connection I can have with myself. And people are talking about food. No, it's not food, it's music. No, it's not music. Oh, it's religion. If you don't have religion, you've got nothing. Oh, no, 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 you don't have to have religion. Spirituality is different. So there you have a group with very, very different cultures bringing in, and then it falls on the facilitator to navigate that, right? So think of it for a moment. If you're doing a group one day a week in an urban area, let's say downtown Durham, you do a group and you have participants from neighboring neighborhoods, and some are driving an hour or two, versus you're doing a group in Asheville, right? You're doing a group in New Bern. Those groups will be very different, right? So the cultural differences, they don't have to be international groups. They just can have, based on the myriad of cultures that exist within the United States, in different pockets of neighborhoods. So these groups bring in a lot more cultural issues that need to be considered carefully. So not just talking about group dynamics, yeah, people need to get along, but looking at it from the cultural point of view. Okay, I think we can go to the next one. Oh, there's a lot on this slide. Okay, so, but do not be afraid. I will break it down for you. So we talked about cultural competency early on through the NASW. So let's take a few steps backwards. So the bottom of the line, we have, I didn't put arrows, but think that there are imaginary arrows going from left to right. So the brightest circle is where we want to be. So cultural awareness, meaning, yeah, I know I'm going to do a group, there'll be people from different, that's just acknowledging differences and doesn't see the broader context. We don't want to be there, but at least, I'm seeing the differences. Yeah, they'll be okay. So for example, I'm doing, I'm organizing a potluck. Every single dish is a meat dish. Some people will be vegetarian. I don't do anything about it. That's really not even on this slide, right? Cultural awareness. Oh yeah, I'm doing a potluck. Let me have one or two things, right? That's some awareness, right? Doesn't see the broader context, but just at least acknowledges it. Limited behavior change. I acknowledge it. I still don't want to do anything about it. That kind of sensitivity is better, acknowledges different ways of seeing the world and integrates some changes in practice and behavior. That's very important. Okay, not just recognizing, not just acknowledging, but doing something with it, integrating in my practice and my behavior. So practice is still easy. I could be practicing something in a clinic somewhere else and it doesn't do a thing to me. Behavior change is what we're getting at. Cultural competency. Okay, systems are aligned, respects other cultures, everything that we saw on that beautiful NASW declaration. We need to read it again. And yes, answering somebody's questions, you are welcome to have my slides. These are proprietary. However, this is my 7 years of work culminating, but you're welcome to have those. So yeah, cultural competency is everything that the NASW slide talked about that I couldn't fit in here, but the actions represent my competence, right? On my behalf, on my organization's behalf. So going back to NASW talks about these competences which we incorporate within ourselves as social workers within our practice. Humility is another thing. It is a lifelong commitment. Humility is also saying, I don't know everything. I do my best. I will not have all the answers, but I want to learn. And I want to redress power imbalances. And there's a want there, right? I want to have mutual trust. This is where we want to be. So this is even further ahead than humility. And this is a newer concept. people start talking about things a long time after they surface, right? So this is one of those things. People are talking a lot about cultural humility right now, and this is even a glorified version of the competency, and that's where we want to be. Okay, so let's go to the next one. So this says clinical example. Before you start reading it, I will let you read it. So the next 3 slides, I will not, I have not prepared those with the intention of doing a DSM diagnosis here, because this is not this presentation. What we will be doing is that overall assessment of the situation prior to diagnosing. And we are already doing it. We are looking at all the factors. We're just collecting all the information as social workers or a person doing intake. But you know what? It's so tempting to just jump to a diagnosis. Somebody's talking and I'm saying, yeah, this is it. This is all the criteria. I've ruled out everything. I've made my diagnosis in 10 minutes, right? Or based on the phone call that came in even before let's take a break. Let's just look at the presentation in the context of culture, and this is what we're practicing doing. So the next 3 slides, which I have labeled clinical example 1, 2, and 3, we will be doing just that. So just like taking off the diagnosing hat and just doing a careful consideration of culture. And I will now let you read it. The first bullet point will be just like demographics, and the second one where I'm saying looking beyond is just, let's just use a minute to read each of these slides. Sorry, I talked too much and interrupted your reading. Happy reading. Laura, can I get the next one? Again, same thing. It's just for reading. We're not diagnosing right now. Can I get the third one, Laura? Is it tempting to start diagnosing? But we're just holding off on that right now. I hope that this was enough time to read the 3. We're going to the next slide, and which is also an example, but it's different. So here I have given a scenario where you have an inclusive and very well-known practice, and then now you have all these clients coming in, and I have just given the first bullet for everyone and not given the looking beyond. And that's our own internal mental process that I was trying to get attention towards. Each one of these could be here as a result of some form of hate crimes. or hateful attitude. And there is a spelling mistake in number 6. Failing. Her class is not falling. And this happened because, you know, how you see the checkbox and when we're filling those forms that says, I am not a robot. So I am not a robot. I made the spelling mistakes. Thank you, April, for that comment. Yes. So this was a practice stemming from the first 3 slides. We don't have enough time to cover everything, but this was not the intent to make everybody an expert. And a lot of us are experts in what we do, and we do so well. But then for that case, this is that road speed limit sign. And then it just takes our attention back to that. I think this is enough time. We could go to the next one, but I'll let you decide because I could be too quick sometimes. All right, takeaways. All right, takeaways. What about us, right? It's all about the client, but look, I got to be feeling well too, right? So first of all, I hope everybody's doing all right, relatively all right, or trying to be all right, or will be all right now. What about us? What do we have? System for the therapist. Now, if you remember what was in the prior slide, the list of all those clients, everybody comes in at the same time. That's a lot. That's asking a lot. These are not regular everyday cases. And this is what we're seeing right now, right? So do I have a support system in place as a therapist, as a service provider, as a clinical social worker? If there isn't one, there needs to be one. And if there is one, who are these support systems? Peers, supervisors, networks? It can't be just family, because there has to be a clinical, professional, social work kind of support also available for us to be able to process the kind of cultural considerations and the kind of services that we're providing. For collaborative versus siloed structure for the therapist, right? We need to have collaborations. Look, I cannot be an expert on everything. I might know a thing or two about culture. I could talk about trauma, but foster care, I don't. And I'm not going to, and I shouldn't be expected to know everything about that system or other systems. And I would want to reach out to somebody who has expertise in the foster care system, right? So am I being collaborative? Are there opportunities for me to be collaborative, to have collaborations? What's available? Are they available, but I haven't explored it? It's just a reminder for us. We feel siloed. Our work could be siloed. It is more so because I could be working from right where I'm standing right now. This is where I eat. This is where I talk to my family. This is where I talk to my clients, right? I could be really siloed in one spot right now. This is really hard. So more so a need for collaborations, right? Reaching out. Are we asking for help? Oh, I don't need to ask for help. I help people. Why should no, I should be able to help myself. No, I can't. No, that's not right. So we should be asking for help, and it's okay, destigmatizing within our profession for each other, right? Doing so, encouraging others, and offering if we think somebody might need it. So this just destigmatizing this whole culture for professional social workers. At what point do we refer out? Well, yes, very important. We may not be able to help every single client that we see, right? I could put a lot of time and effort and energy into being culturally well read, humble, competent, all of that. But there's some things I just can't navigate. I just don't understand. You know what? In that case, I should be able to refer out and not feel bad about it. I cannot help every single person, right? I may not be a good fit. That client may not be a good fit for me, or it is just something that I just am not ready to do at this point in my time. That's when we refer out and not feeling bad about referring out. Self-care, very, very important. Reminder to myself and everybody here, let's do something to take good care of ourselves. Thank you for spending 2 hours of your time today with me and in this very, very wise group of folks. We can go to the next slide. Yay, it was the end. I am happy to open it for discussion as I had committed to. I have left 45 minutes for discussion time. We can use it as we see fit. So questions, discussions, comments, let's talk.
All right, Erum, before you. If we're seeing a client and we are having trouble with that therapeutic alliance and we think that it has something to do with maybe with culture, how many sessions would you give it, or do you have any thoughts about how long to stick with a client before we think about referring out or that kind of thing?
Well, I think, is this your question or did it come from somewhere?
It's just a question
Okay. Yeah. I have had from experience, the first session is not always the one that I have achieved total therapeutic alliance or trust and rapport with. So I will give an example for one of my recent clients, that when I do see children or adolescent, of course, it's with a parent or a guardian. So sometimes that involves talking to the guardian ahead of time, right? We always do that, phone intake and then actual. But what I do is I also, when I meet the first time, whether virtually or in person, with the parent and the guardian, then I start offering structured time to the client and the parent separate from each other. And then so see them together, give them a part time, and then see them together again for closing, etc. So in one of those situations, it wasn't even so much of a cultural issue, but because I had talked to the parent earlier, I was told, well, you know my mom more, and I think you like her more. So it took me 3 sessions and to address. And in fairness, I said, I understand why you would say that, but I have had a very long conversation with her. And yes, I do know her more by that definition, right? So I think the most it has taken me is 3 sessions, but it could be very different from the setting. It could be very different from what experiencing at that moment. The client may be coming from a huge betrayal and does not want to trust the therapist. Why should she or he or they trust me, right? So it's fluid. I don't have a definite answer, but if 10 sessions passed and there was no alliance, or 6, I don't know, 10 is too much. Let's say 6 sessions passed and there was nothing happening, or there wasn't, I wouldn't go past that. But I think the most I have is 3. But then it would be the professional judgment of the therapist with in communication with the client. And what do you think? What are your thoughts? Do you think you would be helped more by a person who understood things about you that I'm not able to understand, so making it mutual, not just referring out. I think referring out should be mutual. So
There's a question in the chat and it says, how do you go about obtaining that cultural lens if it's not on the intake?
it is not on the intake. I have not seen any intake forms with a cultural lens. It's unfortunately, a lot of intake forms are structured in a way that providers can get paid. There are certain things they need to know because they will get paid based on that. And if those areas are left unfilled or blank on a computer, then they won't get paid, and they are very concerned about that. And that's it's the whole health and mental health system is not geared towards spending time, for example, in understanding a client culturally. Some people who are able to, either through their own practice, private practice, or through their organization supporting them, they say they don't even do anything in the first session. They just talk. So that is a luxury that very few of us can afford, but those questions are not always present. And sometimes if they are present, they may be embedded in other questions that it's easy to miss the cultural side of things. So for example, family history, when it just becomes a question, you are just going through a list of questions with the client is just answering because they just want to get over with it. There's a high likelihood of missing the cultural information in those questions. Does it answer that?
I see Paul. Do you want to ask a question, Paul?
Yes. Good evening, Erum. And I want to ask, what is the best way to gain like what you would say cultural competency? Is it doing research, just from your own perspective, doing research on different cultures, or will it actually be engaging someone from that culture to get a better understanding of their perspective?
Yeah. Thank you, Paul. I think it would be a mix of both, but I think the first step would be to recognize that I am ready, and acknowledging that I didn't have that information. I don't know what I don't know. Having the mindset, I think it sets, because uh, we may be seeing a lot of cultural information, but the society and the forms and the agencies don't prepare us to look at the cultural side of things. So we may have those out there already, but missing out on those. So creating that awareness in us that I'm going to look beyond these is there family history of violence, but putting the cultural lens on, so that having that awakening and readiness, and then doing some of research, some of engaging. Well, a person might say, well, I don't have a lot of opportunities to engage with people from different cultures, so what do I do then? So then, yes, reading, researching, and talking to people. So I think networks that would be able to share information from what someone has an expertise on, and sharing it with others who may benefit. So I think having creating some kind of a group that talks about it, just a peer support. So for example, when we have the A license, right, LCSWA, we are mandated to have that supervision. We sometimes dread it because it costs money and we have to do that and get this document signed in. But what is an awesome thing? We are able to process now. Let's say 2 years, or 3 or 4, whatever years it took me to get my license. I'm done. I'm out of it. Today is day 1 of my unsupervised work. Now I have this client. What do I do? So the need for that processing is never gone, but it takes a different form. So we need to have that awareness. It doesn't make us small, saying I'm good now, I know everything, right? So it has to be some kind of processing, peer support, professional networks, something going on. I think that would be a good way, because I can't meet everybody from every culture, and that's an unrealistic aim, and I'm not going to subject myself to that expectation. Make sense? Thank you.
So, as we were talking, this is Alexis, by the way. Was researching. I seen somebody ask, was there like something on the assessment or something of that sort? I just found a culturally responsive questionnaire as it relates to cognitive behavior theory, and they have a lot of culturally responsive questions on here that you can ask clients. I don't know how I can share it because it's on my laptop, but I can like turn my screen around. How to do that? Okay, but they have questions as it relates to gender roles,
Mm-hmm.
family, community focus, discrimination experiences, children and youth, religion, spiritual beliefs and practices, views of mental health. I mean, they have a lot of questions. Language, sex, sexual identity, orientation. They got a lot of stuff on here. And I have questions under all of these different topics. So this would be something good to do if anybody does run into these problems, culturally aware problems. You take some of these questions and ask your clients wherever you see fit. I think that would be great, and I'm glad this is on here because I would have never known if I wouldn't have came here to the training.
Yeah, thank you so much for bringing that to everybody's attention. It is always helpful, the more we read, the more knowledge we have. It may not seem relevant at the time, but there will be a time you'll be able to pull from that, or like you mentioned, to everybody. So now we all know there is something out there. I could have my own short list. So remember when we had that slide with a lot of the respectful model, and I suggested that, okay, if you don't want to use this, or you want to modify based on the area that you're serving, geographical area, or the clients, you can have your own, right? So the more we read, the more we are able to navigate, and even the difficult questions that we reading, say, how am I going to ask, right? The more reading and practicing and going over it, it becomes easy to ask those questions. So for example, we talk about biopsychosocial a lot, but not biopsychosocial spiritual as much. And then also when we talk about spirituality, we don't explore clients' religions. We're like, no, that's their own business. But no, we should, because as social workers, we are in the best position to explore the interfaith, have the interfaith dialogue, to explore religion and how it is, it fits in a client's life. For example, a client, to him, her, or them, their religion could be their anchor, and I could be totally ignoring that, whereas I could acknowledge that and use their anchor to ground them further. And then I don't have to be talking about the religion, but incorporating that within the culture, right? So yeah, so the more we, it's hard, those are hard conversations, but the more we study, talk about, seek peer support, it becomes easy because somebody may have a tip for me, right? So there was a question about reverse racism. I don't think so. So for example, one of the examples that I had, I think it was number 3, if I'm correct, that one of the clients who was born in the United States, but then was parents were not born here, and was struggling with the Eastern and Western values and all of that. That client was sent to me, and it is. Conversation sometimes, but it wasn't reverse racism in that case, because the client said, for example, to the therapist, I can't leave my family. I think I'm going to see somebody else. And the therapist was like, yeah, that's the best advice I can give you, but go seek somebody else. And that person saw my picture and said, look, I saw your picture. I know nothing about you, but I think you might be able to help me. Can you help me? This is my issue. And of course, we worked it together. But that in that case did not become reverse racism, because that client, for example, did seek services from somebody, thinking that that person might be able to help, but they weren't able to help, and it was a mutual decision. Or so, for example, if a client says that I am bilingual and I would like a bilingual client, or I speak Spanish or I speak Arabic, and can somebody talk to me in Arabic because I don't even know how to say what I want to say in English. And when I use interpreter, the interpreter is inserting her own words in there. It's not, so I think that becomes more of a need, but maybe it is or it is not, or it should be conveyed in a way that expresses it as a need versus a racism, right? So for example, I will give another example. I am working with training some mental health professionals and paraprofessionals in Nepal. And I was selected because I have work and lived experience in low and middle income countries, but I'm trained in the West. So I fitted the role of having Western training, but also having that understanding and knowledge of what goes on in low and middle income countries. And that became the criteria, but it didn't fall under reverse racism. But this is a sensitive topic, and I'm not going to claim to answer every question, every point of it. So I acknowledge my limitations, but the way that I have seen in my work and in my research, if I want to present it as a research issue or an ethics issue, there is room to explore that. Racism is very obvious a lot of times. We can see it, and when it's not, then it's not. So
Can I jump in for a minute, Erum?
yes,
I asked the question
I
sort
knew.
of as being a devil's advocate, but usually, and I'm not a clinician myself, but I do direct service with clients in crisis. So a lot of times when I'm talking with them about resources, I will give them a quote unquote mainstream resource, and I will give them an Afrocentric resource or Latinx central focused resource, and let the client choose which is a better fit for them based on what they think they need. All of the agencies provide the same services, but their focus is different based on who your clientele is.
Yes, and we know from research that any intervention that is geared towards a specific group is almost always more effective than one that is a general intervention for a bigger group. But because we cannot have an intervention for every specific group, we do have a larger number of interventions that are just generic and general. But whenever there are options available for specific needs that are present within a certain group, they're almost always more effective. So yes, but what you're doing is you're addressing their overall needs as consumer of certain services, but then specific needs as it pertains to their culture. Yeah. Does that answer your question? Yeah. Is there somebody else? Yeah, hi.
Hey, it's Sharabia. I was just gonna say, for us to be to ask what would be helpful to in session great cultures. I have a client to chakra rocks, so I allow them to come in and use.
I don't think we can hear you.
Yeah, we're having a hard time hearing you.
I could not hear either because the connection was breaking a lot. So,
Fixing it up.
okay.
Tap on my head. Can you hear me a little better?
Yes.
Okay. I was just saying that I think it's important to ask our clients too what would be helpful for them that they can incorporate in sessions from their culture. I have a couple of clients who are into like meditation and chakras and like the rocks and the crystals. So I allow them to incorporate that wherever they see fit within our sessions, if it's in the beginning, middle, or end, depending on what
we're discussing.
Yeah, very, very good point, and important as well. I will also give another example. So, for example, I was seeing a number of clients um, from the refugee background who very, very, very close and connected families, but specifically the respect for the elderlies entails that the elder is present in the room. Now, the elder may not be able to understand a word of what is going on because, of course, their English skills in each one of these cases was very low, but they had a preference to keep the grandmother or the great grandmother in the room while the conversation was taking place for blessings, and that was fine with me because that is part of their culture, and depriving them of that would not do any justice to trying to create a therapeutic alliance. I think we've run out of questions, aren't we?
Erum, I have a question.
Oh, yeah.
This is Aisha.
Yes.
I have a question and just want to know, have you ever encountered where there might be a conflict of culture between the practitioner or the provider and the client?
Conflict. Okay.
So it could be, maybe as an example, could be religious conflict, or it could be spiritual conflict or something of that nature, where someone, the client may express, um, how they identify with a particular culture or spiritual practice, and that is somehow conflicting with the provider. Have you ever encountered that? Or
Well, as for the religious or spiritual, almost every time there isn't a connection from for the clients that I'm trying to see, and I'm not trying to establish their connection, but trying to be respectful and acknowledging. There hasn't been a conflict for the religion or spiritual platform. There has been a time where the political beliefs were conflict, but and they were quite vocal, and but that wasn't the basis of the therapy. It was just aired in a way that uh, you know giving the freedom of free speech, just doing that and just being respectful of that, but then steering the conversation back to the therapeutic needs of the clients. That was the tactic that I used uh, in that particular case. Parenting techniques, for example, they could be very different between clients and the therapist, and it's like, oh my god. Okay. So I think just having that humility that, you know what, just putting the brakes on for judgment formation, and that because it is a part of a social work training, I think that we are trained for many years to just have to overcome that bias. So, for example, a client saying that, yeah, we go to bed at 11 o'clock, even my elementary school children, but that is their cultural, and not thinking that, you know what, you need to be putting kids to bed at 8 o'clock. They have a school bus coming at 6, but it is not a value that they bring in because they have 11 people living in a 2-bedroom house, and there's no way somebody can go to bed at 8 o'clock. Been situations where there have been a contrast but not a conflict, that so far in my practice that required me to terminate based on that. If it arises, I don't know how I will handle it right now, because I will have to use my professional judgment in a given moment to decide whether this is worthy of addressing the differences or whether it is worthy of referring out. I think if we want to make a hypothetical example and say that there was some difference that came up and I was not able to withhold my bias and it was just clouding my judgment or my ability to provide the level of care that I should professionally and ethically, then I would I would discuss alternatives with the client and put it diplomatically and saying, there may be others that I could refer you to that you may be able to better help you with the kind of needs that um, you have, or the kind of expectations that you have, something like that. But I haven't encountered it yet where I had to terminate it based on that. Yeah.
Thank you.
Thank you. You're welcome. I hope I answered your question, Aisha.
Yes, I really just wanted to get your thoughts on that.
Yeah.
Yeah, thank you.
All
Was
right.
that the final question of the night?
All right. Well, I wanted to thank everybody. It was so nice to see so many familiar faces and so many familiar names. It was really pretty exciting to see everybody. We haven't seen everyone in this format in quite some time. So thank you, Erum, for presenting this information. And it sounds like you're willing to share the slides, and so I can get that out to folks. If there is, everybody should be getting an email within the next 48 hours. There is one person that's calling from a phone. And so if that's somebody that's not signed in as well, if you can just shoot me an email or let me know who you are, because I don't know who that is. But thank you, everybody. If anybody wants to do any presentations like this and do some CE, we'd appreciate it. Just reach out, let me know. Got any, I'm sure you guys are expertises in your own area, and we'd love to hear from you, and your peers would love to hear from you as well. Okay.
I have one quick question. I'm sorry. What requirements would you need to do the trainings? Just so if I know other people, I can extend it to them, the opportunity to them. And for the people who do, like, say for instance, if I did one, would I still accumulate the hours that I need as well?
So that's twofold. So you just need to have something that you can present in an hour and a half. There's no particular requirement for it. Erum was saying that if you do present, that you get double hours.
No, you can get to claim the entire CEs that is being offered to others as a presenter, but there's a cap at 6 per every 2 years. So
Oh, okay.
yeah, so I could if I needed to. I'm always over, so I'm not in need of CEs, but I think I want to put these on mine this time.
The other thing that you'll need is you need a title, you need a description, a bio of yourself, and have it be something that you're willing to be open about and really dig into. We've had people present about, we had one presentation that Sabrina did with America, Alan, and it was about trauma and ADHD and misdiagnosis. That was a really cool one that we did. But if you want to collaborate with one of your peers and you do a dual presentation, I mean, I think the other thing is free. We're looking for people to do them free. It's so that we can keep this free for everybody else so that they can get their CEUs free too. We had tried this little payment thing, and I don't know if you guys know, but the paperwork at NCCU is no joke. And so that just became too difficult a hill to climb. So if we could just make this free and all, yeah. So let me know. In touch. Thank you very much again, Erum. If anybody has any questions, put them in the chat. Stay on. I'll be hanging out for a couple minutes. I think Erum will be too. We appreciate everybody. You hanging out to talk to me, Tanya? You're on mute. Okay, go.
Well, it was between you and I.
I gotta tell everybody that's on.
No, because I was just gonna say, like, I was just gonna ask you about, because we're always hiring, and if I sent you an email, like, letting you know that we're always looking for clinicians. Would you?
Yes, please do, because I think people are tired of hearing from Freedom House. They'd like to hear about some other opportunities. So
Okay. And
Freedom House is the only one that sends them to us.
has anyone ever found, like, I'm not a public speaker, I'm not at all, but what I've learned, like when I'm interviewing a lot of new clinicians, they don't know the process as far as getting an NPI number, CAQHID number. Even if I ask them about credentialing, they don't really understand that process either. They usually answer the question wrong. And so I don't know if anyone has done a training on that. Not saying I want to, but this Lee calling me too. Hold on. Hold on, Lee. I'm talking to Laura. I'll call you back. I'm still on
the WebEx.
Okay. So I don't know if anyone's done a training on that, but I feel like that is something that a lot of the, new up and coming graduates should know.
I think that would be good to let them know. What we have found is that new graduates are so overwhelmed with everything that they have to know as soon as they graduate, between applying for their license and all that, that I don't know how much they'll retain. But if we can work on putting together a packet to say, these are all the things. If you want the licensed route, this is a 15-page pamphlet of things that you need to know. This is what an NPI number is. You're going to be asked for it. This is what credentialing means and why your providers are going to need you to be credentialed and what you're going to need. So that might be helpful, is to put together a packet that we could actually give to graduates.
Okay.
We could try a training too.
No, I'm not like, I don't like the, I'm not a public speaker. I'm working on it, but I just noticed, when I interview a lot of clinicians, new clinicians, they don't really know the whole process. No. They didn't even,
They're like, I got my A. Wasn't that enough?
Right.
I know. Because, right, it's like you're pregnant in graduate school, right, and then you have the baby when you graduated, and now you got like this toddler that has so many things going on that you just can't keep track of everything. It's so hard.
So I'm going to send you an email tomorrow then, just to let you know that we are hiring for licensed clinician. And usually I would say this, because we're looking for a program director for the day treatment. John is transitioning out of that position. I don't know if he talked to you about it yet. Mm-hmm. And, yeah. And usually at YE, we hire A's as the program director. And then usually after 2 years, once they're fully licensed, they move on, which is fine. That's always been our practice.
Yeah.
So yeah, we're looking for a day treatment program director as well. And
that's awesome.
As clinician. So I'll send you an email out tomorrow.
Okay. I mean, these graduates will be so excited. These upcoming ones. We've got some real good people graduating. So
how big is the class?
Oh, I got my numbers here. I think it's like 74.
Oh, wow.
Is that not many? I don't know.
That's I don't know. How many? Our class was pretty big too, though. Yeah.
It's usually like 50 for the one, and then it's, I don't know.
Yeah.
A bunch. 50 for one, and then 24 for the other, right? Advanced standing. Oh, I'm all locked out of my system. I can't look right now, but I think it's around 74. All you need though is one good, right? We just need one good one through there, or a couple good ones through there.
Yeah. All right. So I'm gonna shoot you an email tomorrow.
Okay. Thank you. Good to see you. Bye-bye. Anybody else have any questions? Amma, are you good? All right. I'm going to go ahead and just email me if you have any questions, Amma. Thank you. Oops, I got to stop my recording. Stop. Okay. Stop recording.